Hello, my name is John Scolaro, the University of California, Irvine. I'm going to talk today about the treatment of nonunions with the Precice magnetic nail. Outlines of this talk, I'm going to talk a little bit about nonunion types. I think it's helpful to understand that before we start talking about some of the treatment modalities and the way that we address these challenging problems. Recall just briefly why nonunions occur and what are some of the common considerations that you need to be thinking about when faced with a question regarding magnetic nailing and use of the Precice for treatment of a nonunion. Establish some of the principles of nonunion care, which will be pretty straightforward. Review some of the evidence that's out there. So in case you're asked with regard to what are common practices, what are people published on, what's the literature that to support this technique, you have some data on that. And then we're going to run through a handful of cases to demonstrate the management of nonunions with Precice. It's very difficult actually to truly define what a nonunion is. And the FDA has tried to come up with timelines for different long bones, different areas of the body with regard to how long a fracture fails to progress towards healing before it's considered a nonunion. But in my mind, if I see a fracture, say in the femur or the tibia, and through sequential x-rays, every 2 to 3 months, there's truly no progression towards healing. And there's really no potential to heal without some sort of intervention. In my mind, that's a nonunion that's amenable to some sort of surgical intervention. And again, this takes into patient consideration, what is going on with the patient? Is the patient symptomatic? Are they having discomfort? Oftentimes, these patients who will have nonunions will have what we call startup pain. And so they will have discomfort in the beginning of the day when they stand up or start mobilizing after a period of laying down or sitting down for some amount of time. And so that startup pain, or that pain that it comes with long periods of activity, is very indicative of a nonunion. The classifications of nonunions, again, I think is best described in 3 broad categories. One are the hypertrophic nonunions. The second ones are the oligotrophic, and the third are the atrophic. The oligotrophic is one that kind of just sits in the middle. I think this embodies kind of a wide spectrum. The hypertrophic is where the bone is actually trying to heal, and we'll go through this in a quick second. And so you see a lot of actual biologic activity, a lot of healing effort in the area, and that's opposed and completely opposite from the atrophic, where the bone ends are rounded, very little activity, very little effort by the bone to actually heal. So again, this is indicative of a hypertrophic nonunion. This picture, this radiograph here on the left side, again, this is not treated with any sort of intramedullary device at this time point, but you see the amount of callus forming in this area of fracture. And so this just needs stability. So for these fractures, or these nonunions, these are not the ones that we're really kind of aiming for to treat with a Precice magnetic nail. These are commonly treated with just a standard medullary nail or plate and screw construct, something that just provides stability to the bone, because the biology to heal is actually already present. The ones that I think are most amenable, and the ones that we found greatest success with, are the oligotrophic and the atrophic. And again, the spectrum of kind of the oligotrophic to the atrophic is a little bit muddy, but oftentimes in the oligotrophic, there is some early healing that's seen, and this is stopped or kind of halted for some reason, likely due to some combination of compromised biology and variable stability. And so both of these are radiographs of patients of mine who have had nonunions. And again, you can see the spiral oblique femoral shaft fracture treated with a retrograde or an antegrade nail. And the intramedullary nail is well done. The length, alignment, and rotation of the limb is restored. Is a little bit of fracture callus seen, but the patient is now, I think this radiographs were at about 9 months with lack of complete healing. The bottom right image, again, another intramedullary nail placed for a distal third femoral shaft fracture. And you can see here that these bone edges are not really making any effort to join each other. There's no callus formation. The bone edges have kind of rounded. And so this may actually occur sometimes in the setting of an open fracture, when a fracture gap is left and the patient has gone on to not heal. So these are the 2 types of nonunions that we're really focusing on when we're thinking about magnetic nail use in nonunions. The reason that fractures don't heal, multifactorial. And I think I, again, put these into some larger buckets just to kind of group them in my mind. And So first is the medical and social reasons. And so the medical factors are things like potential renal disease, kidney disease, diabetes, obesity, age, all are medical comorbidities that affect bone healing. Some of the social factors, again, smoking, drug use, other things like that can affect the ability of a fracture to heal. Second is surgery, and I put this in there because, again, there can be iatrogenic reasons why the fracture doesn't heal. If there's excessive stripping of periosteum and soft tissue at the time of the initial surgery, if the surgery was not well done and there is inadequate stability placed, then the patient may have a fracture that goes on to non-union. And I think partially the next category, infection, may be related to the surgical component of the treatment, or may be related to an open fracture. And so again, fractures that are infected, ones that have had an open injury, where there's been excessive soft tissue stripping, maybe a post-operative infection following a closed fracture that was treated surgically. All these are reasons that fracture can heal. Some of these things are can be changed by the surgeon before the non-union is addressed. Again, if we need to make sure we hone the patient's sugars, get their diabetes under control, things like renal failure and liver failure, things that we may not be able to change acutely. Some of the social factors, such as smoking, are reversible factors that can be addressed before non-union treatment. Again, if initial surgery was done poorly, not something that we can really go back and turn back the hands of time to address. And then in the setting of infection, I would not advocate that magnetic nail technology is used. Again, this is a situation where the infection needs to be addressed. The area of the non-union needs to be taken care of and cleansed and debrided, and the infection needs to be eradicated before we address this. I think in general, when we think about oligotrophic and atrophic non-unions, one of the principles that we really focus on is that non-unions want compression. So they want to be squeezed. And the way that we have historically done that is through a handful of different ways. Simple screw placement, such as a lag screw, can be used to compress a non-union. And so after we've debrided a non-union, if we have a fracture plane that's amenable to a lag screw, that's one way. Plates can be used, and oftentimes we'll use plates in compression mode to compress across a non-union. So potentially fixing one side of the plate and then using either the combination holes on the contralateral side of the fracture, or something like an articulating tensioning device, if you're familiar with that, can be used for compression. And then nails. And historically, in the past, we've used nails that may have a interlocking bolt that can be placed in a dynamic slot with a compression bolt placed from the top, or potentially surgeons may have backslapped a nail to gain some compression. But for each one of these three things, again, not considering magnetic nails, that compression is generated, and then there's a period of time where it actually relaxes. The bone is unable to maintain that compression, and then once you leave the operating room, there's really no way to maintain that compression. So if you think about backslapping a nail, you may get initial compression with the backslap, but then that bone actually does have some recoil, and you're unable to maintain that compression. You may be able to get apposition of the fracture fragments, but not compression. And again, there's diminution of force over time, and this has to do with multiple things such as bone quality, implant stress relaxation. So even though we're using titanium and stainless steel implants, this can change over time. And then sometimes if the biology is not favorable, there's actually osseous resorption. So if ever seen a fracture or a non-union that's been treated and that has not gone on to heal, again, there may be actually some additional resorption at that site. And so you may be in a situation where a surgery has been done, a compression plate or a lag screw or something, some sort of implant has been used to try to compress the fracture. The fracture has continued to not progress towards complete union, and you start getting osseous resorption. And there's really no way to go back and address that other than doing another open surgical procedure. And that's something where the benefit of a magnetic nail running compression mode may have real advantages. So there's really no way to recompress at a later time point. In my mind, non-union is ideal for treatment with a magnetic compression nail. Non-unions that have failed previous non-union repair. And so oftentimes this is not my first go-to, but these are the treatment for recalcitrant non-unions that have failed a bone grafting, failed an exchange nailing, something of that sort. So there needs to be something else done to the bone to heal. Want to make sure you have favorable non-union morphology. And I'll talk about this in a quick second here, but thinking about how the two bone ends of the non-union are going to mate. And so take a look at the radiograph here on the right side. This is the patient of mine, and I'll show this case a little bit later. And you can imagine if that non-union is compressed, the proximal and distal fragments will actually unite very nicely with compression. And so there won't be any real loss of alignment or length, potentially just less than a centimeter. So again, thinking about non-unions where there's a small gap, especially in the lower extremity, because you don't want to sacrifice a large amount of length. Maybe outside of the conversation of this webinar or this presentation, you can talk about compressing a non-union, then going back later and using the magnetic nail to lengthen another time point. Not something that I've done, but definitely a possibility. Obviously, you want an intramedullary canal that's favorable or amenable to an intramedullary nail. And you want to make sure that there's viable bone ends. And so this is something that oftentimes can be determined at the time of surgery and may be able to be identified based on previous radiographs taken. So if there's no concern that the biology is compromised such that you're not going to be able to get good healing, something you want to consider. And then we'll talk a little bit about the metadiaphyseal mismatch. This goes on to favorable, or this kind of relates back to favorable non-union morphology. So compare that previous image, or this previous radiographs that I showed you, with something like this. And so this is a patient who you could imagine replacing that standard trauma nail, which is in place right now, and placing a magnetic compression nail. You have a limb that has varus malalignment. There's a non-union morphology is actually pretty poor. There's a separate anterior cortical segment. There is potentially an area in the posterior cortex which would line up, but other than that, really not a large surface area on the tibia that would be able to merge, and you'd lose a notable amount of length looking at the gap in the posterior cortex of that tibia. So you want to make sure that you have a good morphology to mate or to compress to get good healing. You want to make sure there's not any osseous roadblocks. And so again, this goes back to the free cortical fragments, callus that may be present. Again, things that would prevent you from compressing along a long bone. It's very similar actually to thinking about what we do when we do plate-assisted bone segment transport or other distraction osteogenesis. You want to make sure you have a clear path for the distraction osteogenesis or the transport segment. Same thing when you think about it in reverse. You want to make sure that you're not going to be blocking yourself because you have a cortical fragment or something in the way of the two major proximal and distal bone segments mating. And again, malalignment is something that I think is really important here. There can be efforts to correct malalignment. And so if you're planning on correcting malalignment, then I think you can go back to thinking about a magnetic compression nail. But if there's no effort or no thought to changing the malalignment, you can imagine on these radiographs on the right-hand side here, compression of that fracture just without correcting that malalignment would probably drive this tibia into greater varus. So let's think about some of the non-union morphologies that we really like. So again, if you have flat bone ends or something similar and you're able to compress those, you have a large surface area that's going to be mating or joining and gaining compression across that whole area. So this is kind of the ideal non-union morphology or something very similar to this. If you have a non-union that has point ends or maybe a medial or lateral or anterior or posterior cortex only, and those compress, again, you lose a large amount of surface area. And so while you may get healing at that very point area, this is not really ideal. And then similarly, we talked a little bit about metadiaphyseal mismatch. You can imagine in the proximal or distal end of a bone, if you have a diaphyseal segment going into an end segment and you compress, you may get intussusception of that diaphyseal segment into the metaphysis. And so you may lose a lot of length. And so when I think about morphology of non-unions that I want to treat with a compression nail, these are not the ones that I'm looking at as really ideal candidates. It's kind of the ones on the left, or as I showed you before, ones that would mate really nicely and allow for good surface area for healing. Some of the evidence behind this practice has been established, and this goes back to even 2017. This is a series that was published from Tracy Watson and Roy Sanders about compression nailing of humeral shaft fractures, which are at risk for non-union. So they use the magnetic nail, run on reverse to compress those fracture edges. And again, I think you could look at some of the radiographs and maybe question some of the non-union morphologies that they were using. But even still, I think they found very good results with this technique. And this was their protocol. They had an initial 2-week follow-up with compression until the gap was eliminated, and they started to see callus formation. So this is something that's really interesting to think about, because if you go back to the way that we think about fractures healing, in general, compression does not lead to callus formation, but the presence of a nail oftentimes allows for some secondary bone formation to heal with relative stability. So we're kind of getting the best of both worlds. We have an intramedullary nail in place, which is quite stable for most long bones, and we're still be able to gain compression. And then they're following these patients up every 3 weeks with continued compression, somewhere between a third and a half millimeter. Another series published out of the group in New York treated 14 non-unions, 5 in the tibia and 9 in the femur. And again, over half of these were atrophic. The other half were kind of in that oligotrophic range. Almost all of them were diaphyseal. So again, not treating end segment non-unions, but treating ones within the diaphysis. And they would be doing monthly compression in the clinic. And they were looking at the deflection of the interlocking bolts. And I'll show you a schematic here briefly from this paper to kind of understand how much compression they were generating. And they had 14 of these fractures go on to non-union. Their technique was an open non-union takedown. And we'll talk about the technique or the thought behind taking down the non-union. They'd pre-distract the nail, make sure that they had cortical replacing screws to support the nail, over-ream the nail by 2, which is pretty standard. Most people are over-reaming by 1.5 to 2 millimeters. And then compression in the operating room, and then in the outpatient basis. And so here's an image from their paper. And so you can see that on the left-hand image, they were able to compress in the, this is probably post-operatively, maybe at 2 weeks or directly post-operatively. They were getting some deflection of the interlocking bolts. But interestingly enough, as time went on, that deflection relaxed somewhat. And you can see that those interlocking bolts went back to a more normal straight state. And then they were able to generate compression again. And so you can see the magnetic nail there continuing to compress with that distal segment, moving closer towards the proximal portion of the nail, generating more and more compression. So they were using the interlocking bolts as kind of an indication of how much they were compressing in the clinic. This is a series that we're going to be presenting later on this year on 20 patients treated at a handful of centers here in the U.S. 1 humeral non-union, 10 femur non-unions, and 9 tibia non-unions. Some of them were previous septic non-unions, in which the infection was eradicated and then treated, and then 15 were also recalcitrant, which means that they had all been treated in some way, shape, or form with a non-union attempt and failed. In half of them, bone graft was used, and we had 13 of 16 go on to non-union, or 13 of 16 go on to healing. 2 are still kind of ongoing, and then we lost 2 patients to follow-up. So again, I think the amount of data is slowly building on this technology and this treatment technique. This is my preferred technique, and so something I just wanted to share with you. I do take down the non-union. I think it's important to go and take down the scar and non-viable tissue in the area of the non-union. Almost like a docking site, I want to make sure that the bone edges are healthy, that I have good bleeding bone edges. And depending on where the non-union is and kind of the age of the patient and my general gestalt of what's going on, I may use autograft from a local area, such as the proximal tibia or distal femur. And then most commonly, I'm doing an osteoperiosteal decortication. I'll talk about this in a quick second. And then we're distracting the nail as typical, over-reaming 1.5 to 2. And then I'll get compression in the operating room, and then I'll bring the patient back every week or every 2 weeks, kind of depending on where they live, and continue to compress anywhere between 0.25 and 0.5 millimeters until I start to see some early healing. And I'll show some pictures of this as well. So one of the things that's maybe worth understanding or learning a little bit about is this Judet osteoperiosteal decortication. It's a kind of a mouthful when you talk about it, but really all it means is that you're just using an osteotome and keeping the vast majority of the muscle attached to the periosteum, and then decorticating or creating bleeding bony surfaces in the area of the nonunion. So this brings in a lot of biology to the area. Oftentimes this is used to treat some nonunions without graft even. So this is the way that it was originally described by Jude. So it's something that I think is really beneficial. If you're going to be going in and taking down the nonunion, I think it's very helpful to get some good biology in the area as well, which helps healing. So I want to go through some recent cases in which I've used this technique. And I think this helps identify some of the indications that I have for use of this technology and kind of what I'm looking at with each one of these nonunion cases. So this is a 62-year-old female, right hand dominant. She had a right humeral fracture 2 years ago, was treated initially non-operatively, was then taken back to the operating room for ORF. She had an early failure of a plate and it was converted to an intramedullary nail. And she had a revision nail and then presented to me with persistent pain in the right upper extremity. So this is how she presented to me after her plate had been removed and her nail had been placed, and she's about a year out. And so you can see the nonunion site there. She has a little bit of a larger soft tissue envelope. So I think the CT scan helps you here. And so again, the primary nonunion line, you can imagine if that distal and proximal segment were compressed, you'd have a good area of fracture cortex or bony cortex, both medial and laterally, as well as anteriorly and posteriorly. And that's the sagittal image there in the middle to be able to get good contact and healing. And so we brought the patient to the operating room, took out the intramedullary nail. You can see the magnetic nail placed. And then between the middle image and the right hand image, you can see that that nail is now run on reverse, and we get good apposition of the nonunion site. And so we were actually had the surgical incision open. We're watching this, and we're able to see this nonunion come together and the bony edges compress. She's 60, I think 2 years old, as I said before. And so we did add some biology to the area after decortication. And so a little bit of allograft to the area after we had debrided the nonunion site. So this is her final radiographs. In this case, it was just done a couple of weeks ago. So I haven't seen her back in clinic, or maybe she just came back this last week. 57-year-old female, left closed femur fracture 2 years ago, treated with a retrograde intramedullary nail. Then she had an exchange nail. Then she was bone grafted. And she comes to me with persistent pain in the lower extremity. And so here we see a fracture that does have some biological activity, right? There is some fracture callus that's seen in the area, but going back through her sequential radiographs, this is largely the effect of the bone graft which was placed. And so she did have what I would consider an atrophic or kind of oligotrophic nonunion before her bone grafting. And she has a very large diameter nail, which was seen. I can tell you that I think when we took this nail out, this is a 13 or 14 millimeter nail. So they had, re-reamed her, placed a larger nail. And so now she has this very transverse nonunion. So something that's really ideal for a magnetic intramedullary nail to treat this nonunion. So you can see here, we've taken the previous trauma nail out. We've placed a retrograde magnetic Precice. And what you do see here is the addition of cortical replacing screws. Remember that I said that the nail that was placed before was a large diameter nail, and you can actually see the stigmata of that nail in the bone. So there's I think it was, like I said, probably a 14 millimeter nail. And so now we have a magnetic nail in place. We place these cortical replacing screws, or these blocking screws, so that as we compress, we don't see any toggling or induction of deformity with compression. And so the nail is placed. The cortical replacing screws are placed distally to support the nail. And you can see that we've done an open decortication of the area. You see some of the bony fragments on the lateral view, which have been elevated. And so we compress her in the operating room, and then we're going to continue to compress her in the clinic. And so I'm hoping that she goes on to union because she does have a very favorable non-union morphology. This is a 35-year-old female, status post left femur fracture 10 months ago. She also had an exchange nailing at an outside hospital and presented with persistent pain. Saved some more fluoro images to show you a little bit more what I've been talking about. And so again, large diameter nail after an exchange nailing, and you can see a free cortical fragment on the medial side. But other than that, very nice oblique non-union site, which I think is amenable for compression. You're going to get good cortical contact on the medial and lateral side, as well as the anterior and posterior side, with a magnetic nail run on reverse. And so similar technique here. Again, you can see the stigmata of that previous large diameter nail. And so The retrograde Precice nail is placed. We place some screws around the nail to support it so we don't induce any sort of deformity. And then here I do this open non-union takedown. And so I'm marking out the site of the non-union with my tonsil here on the left-hand image. And I go in and I use a sharp osteotome to decorticate the area of the non-union in order to bring some biology to the area. And here you can see we use the fast distractor compressor and the non-union site on the left-hand image, and then run it on reverse, and you're able to see that the bone edges are already starting to compress. So I'll run this in the operating room until I feel like I'm happy with the amount of compression that I'm getting, and then stop, and then I'll bring the patient back again in the clinic and do this more. And so you can see this is our initial post-operative images with the nail in place. The staples are still in place here, and here's where we are currently. So she's otherwise doing well. You can see she's starting to, you see that fracture gap has closed down on the AP image there on the left, and we're starting to get some good healing on the lateral there. So otherwise, pretty happy. But again, I think the importance here is highlighting that you control that distal segment, especially in the metaphyseal area, because you don't want to induce any sort of deformity when you're running this nail on compression. So let's go through a couple completed non-union cases. And this will highlight, I think, the benefits of this technique, and then we'll wrap things up. And so this is a 64-year-old female, a recalcitrant left proximal femur non-union. She reports that she had 5 previous attempts, proximal femoral locking plate, small amount of varus deformity to the proximal femur. You can see that there is evidence of an old nail which has been placed. CT scan which shows her non-union. Again, multiple attempts at non-union repair. She has a little bit of biology in this area, so the fracture has tried to heal but hasn't really completed. So our plan was to take down the non-union, remove the plate, and then change it to an antegrade piriformis compression nail to make sure that we maintained good alignment of the femur. Then we're going to compress in the operating room and compress in clinic. Just some images showing identification of a good start point in the piriformis fossa. Placement of the nail. I did place 2 screws independent into the neck and head, given her age and my concern for any sort of potential stress fracture or stress riser in the proximal femur. And then you can see her at 1 month, 4 months, and 1 year. And so she's healed now at 1 year. Non-union is completely healed. She's walking, otherwise doing really well. And so a lot of these patients, once they start to heal, and oftentimes this occurs around the 3 to 4 month mark, with continued compression, they do very well. Another patient who had a right closed femoral shaft fracture treated in the Midwest. Well done nail, no complaints here. Length, alignment, and rotation restored. But she goes on to non-union. She's not healing at 5 months. She's dynamized, continues to have issues with regard to healing, and this is where she comes to me. And so she has a dynamized nail, incomplete union, but otherwise favorable fracture morphology. And so she's at about 9 months now. So this is kind of what we're dealt with. I think it is important to talk to the patients a little bit about potential loss of limb length with compression. Again, I'm not doing this for any critical size bone defects, not compressing gaps probably larger than 1 centimeter. So when I do talk to patients about loss of limb length, it's not very significant. And I talk to them about potential need for a shoe lift if they are symptomatic, but I will oftentimes get standing full-length films to show them or talk to them about limb length. So again, plan for the removal of the nail, periosteal decortication, and then compression. She had a retrograde nail before. I opted to proceed with an antegrade nail. And so this is what she looks like post-operatively. Running this on reverse, 3 months, 9 months. And this is her final radiographs. I think the last time I saw her. So she's gone on to complete healing. And you can see that fracture line, that non-union site is completely been eliminated. It's a patient who had a open proximal tibia fracture. So we've gone through some femur cases. We go through some of these pretty quickly. Again, femoral nail, which is placed in the 10 months. Patient has some varus deformity and has gone on to non-healing. Take the patient back to the operating room. And again, this is my first attempt at non-union repair. Wanted to correct that varus deformity. And so revise my nail, new start point, better alignment. So overall happy with this, but now at 6 months, still failing to heal. So I want you to take a look at that non-union morphology. and think to yourself if that's one that's amenable for compression. And I would offer that I think it really is. The fibula has done a great job of healing, and that's something that I think you have to consider in the tibia that is not a factor in the femur. So thinking about how the fibula may potentially block me, but then looking at that nonunion morphology and thinking that, look, that would be one that would be really nice to compress because I have good compressible surfaces, both in the medial and lateral cortex, as well as the anterior and posterior cortex. So plan here to remove the nail. It's going to do some autograft, given the fact that this patient had already failed one nonunion repair, do another fibular osteotomy, and then my compression protocol. And so here's a magnetic nail in place, cut the fibula at a different position, because again, I'm not having any issues with the fibula healing, but the tibia continues to give me some issues. So allow myself some room in the fibula to heal and compress that tibia. And this is the patient in clinic compression. In 5 months here, you can see the fibula is healed. You can see that gap in the fibula has decreased. And so you know that I've been compressing the tibia, and he's gone on to complete healing. I think this is the last time that I saw him as well. A couple more cases, then we'll wrap up. 22-year-old male, open tibia fracture. This was initially treated in outside hospital. Fixed well done, well-aligned tibia. Again, a little bit of a larger gap than I would like, but has good anterior and lateral cortex. The posterior cortex is intact for the most part, just missing a little bit of posterior medial bone. And so he was sent to me with this fracture and something that I thought would be amenable to compression nailing. So here's the CT scan again, wanting to really understand the morphology of that nonunion and see that the only area that I'm really missing bone on is kind of that posterior medial cortex. So that was going to be an area that I was going to supplement with some autograft. So I was going to remove the nail, take down the nonunion, use some iliac crest for the posterior medial surface of the tibia, make sure that my fibula was mobile, and then again, compression technique is as I described before. So here's my Precice nail in place and compression in the clinic. And then here's at 3 months that bone graft is really incorporated nicely. You can see the amount of compression that I'm getting and how that nonunion site is completely merged. And so I've got great healing in this otherwise healthy male who had a bad injury. So really happy. And again, my alignment is nice, which was set up for me before by the initial surgeon. So making sure that that alignment is good will help to ensure that you succeed in the operating room. And the last radiographs here at 4 months, and he sent these to me from an outside provider. So the nonunion is completely healed. 47-year-old female, autoverse pedestrian, open injury, complex fracture, segmental, short distal segment. This was done with initial trauma nail. Again, happy with my alignment, but the patient goes on to nonunion. This is the case that I showed you before when I was talking about nonunion morphology. Had no issues with the distal segment healing, but the diaphyseal segment was recalcitrant. And so wanted to get this patient kind of over the edge. And for soft tissue reasons, I think you could take a look at the soft tissue shadows on these x-rays, and you can see that there's a deficit of soft tissue on the anterior and medial aspect of the lower extremity. So I wanted something that would be good for her and didn't require a lot of large incisions. So get the patient to the operating room, identifying where the magnet is, compressing this nail in place. And here you can see the compression take place. And then at 6 months here, he's gone on to complete healing. So I did a very minimal takedown of the nonunion in this patient for soft tissue reasons. Didn't use any sort of autograft, but again, good success with this technique. So let me wrap things up. I think magnetic nail technology is really a viable option for recalcitrant nonunions. It may not be the first thing that you think of, but in those difficult nonunions that have already failed an exchange nailing or some sort of other intervention, this is a great option for those oligotrophic and atrophic nonunions. You want to make sure you go through your standard workup of infection, any sort of metabolic problems, making sure that you address any of the things such as smoking that may decrease bony healing, and then getting a good understanding of the nonunion morphology and the limb alignment. So whether that requires getting full-length standing films or a wider image of the bone, whether it's femur or tibia, to understand the alignment, make sure that that's set or it needs to be corrected before you start thinking about use of the magnetic nail. You want to make sure that you also consider alignment when you're using a nail and compressions to not induce deformity. So whether that means supporting the nail with cortical replacing screws or just using a little bit of foresight to understand what deformity may occur with compression before the operating room. Multiple protocols exist. I showed you what was done by Dr. Watson, Dr. Sanders, as well as a group out of HSS, and talked to you a little bit about what I do as well. I think we're still figuring a lot of this out. I would still favor takedown of the non-union. I think that removes a lot of the scar and non-viable tissue from the non-union site. And I'm, plus minus on bone grafting. I think a lot of that has to do with the patient's age as well as what's going on. But hopefully we'll have some more information about best practices soon to come. But I think the greatest benefit is that it really allows for on-demand compression that is unable to be achieved with any other implant. And so again, like I said before, you can use an articulating tension device, you can use a compression plate, you can backslap a nail, you can use a compression bolt on a standard trauma nail. But the minute you leave the operating room, that you lose the ability to manipulate and control that non-union. So there's no way, even with bony resorption or anything like that, to go back and compress more unless you go back to the operating room and do another surgical procedure for a patient. So I think the benefit here is that you can continue to follow these patients and use the magnetic and use the external remote control device in clinic and compress them in clinic to gain treatment of the non-union. So I think it's really, that's the true advantage of this without bringing them back to the operating room. It's not, not expense. It's not any sort of, real issue for the patient. And most of the times they tolerate it very well. I've had a couple of patients discuss or note to me that they have some discomfort around some of the interlocking bolts, but that's really temporary and it's never been a real major issue for me.